and share a little bit about your program or an upcoming event. So I'd like to introduce our first presenter. Our first presenter is Dr. Midori, Dr. Gigi Midori, and she'll be presenting on how to recognize and treat traumatic brain injuries. She's the medical director of the emergency department at Westchester Medical Center's Health Alliance Hospital in Kingston. So I'm going to stop sharing so that she can share and start her presentation. So welcome, Dr. Midori.
Great. Thank you so much for having me, and it's a pleasure to be here. I'm going to talk a little bit about traumatic brain injury, as was mentioned, and how to recognize it, and some of the treatments and prevention strategies. So just a quick note about myself as a way of introduction. I didn't start out as a physician. I went to Williams College nearby Williamstown, and then majored in English and psychology. And then after about 10 years at W.W. Norton in publishing, decided to go to medicine and found my way at Weill Cornell Medical School, and then did an emergency medicine residency and really liked to focus on community medicine, which is what I've done since finishing my residency. And now I'm the medical director here at Health Alliance Hospital in Kingston. So I'm going to talk a little bit about what is TBI, traumatic brain injury. How do we categorize it? Spare me through some of the brain anatomy, but I think it's important to understand it in order to understand the impact of brain injury. I'm going to talk a little bit about some of the functions of the brain, types of injury, mechanisms, and then who it affects, and then how do we prevent and treat some of these injuries. So starting right away, what is traumatic brain injury? It's injury that results when any kind of external force impacts the head with sufficient intensity to cause damage to the brain, and it affects how the brain works. And it can be mild, moderate, or severe. It can have long-term consequences, including visual difficulties, cognitive deficits, headache, pain, sleep disturbance, post-traumatic seizures. And at its most severe, it can lead to permanent disability and even death. In terms of who is impacted by it, every year it impacts about 2.5 million Americans, and that results in almost 70,000 deaths, or about 190 deaths a day, and another 90,000 suffer permanent disability. You know, many of us are familiar with some of the famous people like Natasha Richardson, who suffered brain injury when she was skiing at Mont Tremblant. She was on a beginner slope and hit her head, and then suffered severe headache. 2 hours later, she was flown to Lenox Hill Hospital in New York City, and 2 days later, she had died. There are many others, Bob Saget of Full House fame, and Steve Wozniak, and Sonny Bono, another ski accident, our own 16th president, Abraham Lincoln. But most of the people who suffer traumatic brain injury are people like you and me. They're normal people. They're not famous. They're young, they're old, and many of them, this was sort of an unanticipated, and they certainly are not famous. So here's one guy who became famous because of his traumatic brain injury. This is pictured here is a guy named Phineas Gage, who in 1848 was a 25-year-old, and he was working construction on the railroad when an iron rod was driven through his skull after it hit some dynamite. And it, as you can see, lost his left eye. And he became famous because he suffered what was thought to be, he recovered from what was thought to be a completely unrecoverable injury at that time, and became famous because of it. But he also was thought that this injury led to blindness in his left eye, but also thought to change his personality. So he became impulsive and impatient and indecisive, and became socially inappropriate. And a lot of that was thought to be secondary to the brain injury that went through the frontal part of his brain. So how we categorize brain injury is we can talk about primary versus secondary. Primary meaning the damage is immediate, and secondary is how the secondary changes as a consequence of the initial injury. But more commonly, we think of these as penetrating versus non-penetrating. Obviously, in the case of Phineas Gage, that was a penetrating injury, which means it's also referred to as an open injury that occurs when an object penetrates the skull. And that could be a bullet or shrapnel from a blast injury, or a penetrating weapon or an object such as a hammer or a knife. And these penetrating scalp usually only damages a part of the brain tissue. Non-penetrating injuries are referred to as closed injuries or blunt traumatic brain injury. And these are caused by external forces that are strong enough to injure the brain inside the skull without actually penetrating the skull. These are far more common and make up the majority of all traumatic brain injuries. And they're usually caused by falls, motor vehicle collisions, sporting injuries, blast injuries, or being struck by an object. And then there's some injuries that, such as explosions or like natural disasters and other extreme events that can cause both penetrating and non-penetrating injuries at the same time. As I said, you can spare me with a little bit of anatomy, not much, but I think you'll see how it helps us to understand the terminology and then the impacts on the brain. So the brain is encased. You see the very outer part here is the skull. Obviously, that's very hard bone. And then under that are these three layers of they're called meninges that cover the brain tissue. The first of those is the dura mater. They're all referred to as something mater. Mater means layer, and dura means hard. So that's a hard membrane that's closest to the skull. Just underneath that is that web-like area called the arachnoid mater. An arachnoid comes from spider, and that's cobweb-like. And then under that is the pia mater, which is the innermost layer. Pia means delicate. And cerebral arteries and veins travel in the subarachnoid space that completely are enveloped by this pia mater. And we'll see in the next slides, we talk about subarachnoid or epidural, and those refer to locations. So subarachnoid is under the arachnoid layer, subdural is under the dural layer, and epidural is outside of that dural space. But together, these meninges, they support the nerves, the blood vessels, the lymphatics, and the cerebrospinal fluid that's found in the central nervous system. So as I mentioned, there are different types of brain hemorrhage, include subdurals, and these are bleeding between the dura and the arachnoid mater. And these exert pressure on the outside of the brain, and they're very common, especially in the elderly after falls. An epidural hematoma, which is actually what Natasha Richardson suffered and died from. These involve bleeding into the area between the skull and that first layer, the dura layer. So it's epidural outside of the dura. And they typically occur when you get hit in the head and then you suffer a skull fracture and it tears the underlying blood vessel. And it's classically the middle meningeal artery. And these are particularly dangerous if they're not diagnosed and treated immediately. When I was in medical school, this was, synonymous with death, basically. And classically, it's a young person who gets hit in the head and they're sort of walkie-talkie. They seem fine, and suddenly they're not fine. And it's irreversible damage if not diagnosed immediately. These are about half as common as subdural hematomas, and they're usually in young adults. Next, we have subarachnoid hemorrhage, and that's bleeding under the arachnoid layer between that arachnoid and pia layer. And those are often the result of trauma, but they can also result from a ruptured brain aneurysm or an arteriovenous malformation, which would not be, because of trauma. And these are the most common type of brain bleeding. And then we do have this one in the middle, which is called an intracerebral or intraparenchymal hemorrhage. And we see those as a result of strokes, but due to hypertension usually, but not usually related to trauma. You just may hear that term. So why the anatomy matters is right here, because the cognitive effects on the brain really depend on what was impacted in this brain injury. So if you impact the frontal lobe, you might see problems with problem solving or decision making or personality, even like in the case of Phineas Gage. if you hit the parietal lobes on the sides of the head, those areas are involved with perception or object classification or spelling, numbers, and visual processing. The temporal lobes, which are located, as you see here, just kind of behind the ears, those areas really control the bulk of our memories and our ability to speak and remember and recognize faces, recognize each other, and much of our ability to learn and hear. And then in the very back of the head, the occipital lobe, that's where vision and visual processing occurs and color identification. The cerebellum is sort of underneath the occipital lobe, and that's much harder to impact with traumatic brain injury, but possible. And that area of the brain controls our fine motor skills and balance and coordination. And then under that is that brain stem, which connects the brain to the spinal column, and it regulates body temperature and our ability to breathe, which is pretty important, our heart rate, our ability to swallow. What happens sometimes is we talk about brain herniation. It's very difficult. Usually we don't see brain injury to the brain stem, but if you can imagine the scalp is it's incredibly dense, right? And so it's unlikely that when you have bleeding, you have something now in a very fixed space, and you can't increase the space. There's just not space to increase inside the scalp, inside that hard skull. So you have bleeding, it's taking up space, so it can push on the brain itself. It can push it from one side to the other. And then when the pressure gets so high, the brain is basically going to take the path of least resistance and go down the brainstem. And that's called herniation, which is essentially a death sentence if that happens, because it impacts things like your ability to regulate temperature and your heart rate and your ability to breathe. So if someone, if we refer to someone with a traumatic brain injury with herniation, that is basically saying if they're not dead yet, they're pretty likely to be dead because of that injury. We hear a lot about concussions, and think of this as like a mild form of traumatic brain injury. Concussion is a type of injury that causes the head and the brain to move rapidly back and forth. People like myself, medical providers, we often describe these as mild traumatic brain injuries because they're usually not life-threatening, but nevertheless, they can really have massive effects on us. And these changes can be long-standing. Even though they don't usually change the structure of the brain, they can vastly change the function of the brain and have long-term consequences. So think about who's affected by traumatic brain injury. You won't be surprised to learn that this is largely adults over 65, have the highest numbers and rates of TBI-related hospitalizations and also deaths. Next comes infants under a year old, and third in line is older kids or young adults. 15 to 19-year-olds have the third highest rate of hospitalization and death from traumatic brain injury, and that's often related to risky behaviors. Adults 65 and over account for 32% of TBI-related hospitalizations and about 28% of TBI-related deaths. And in every age category, males are almost twice as likely to be hospitalized and 3 times more likely to die from traumatic brain injuries than females. We sometimes see that there are delays in diagnosis because not all traumatic brain injuries are immediately symptomatic. Obviously, if someone hits their head and starts seizing, that it's pretty obvious that something bad is going on. But sometimes the symptoms are delayed, and the timing of symptoms might vary with age, but it also might vary with the location and the size of the injury. And it's why after any fall, it's really important to watch for signs of brain injury. And these might include seizures, certainly, but also might be headache, nausea, vomiting, problems with speech, memory, cognition. We often see delays in older people, And that's because as we get older, our brain actually shrinks, it atrophies and shrinks a little bit. The skull obviously remains the same size and you have a less content. So it provides a little bit of wiggle room. If you do have bleeding, it provides a little bit of time before you might have symptoms. And that ends up being problematic in a way because people might seem normal after hitting their head, but may actually have bleeding going on, but not have symptoms from it quite yet. Young, healthy adults have a very tight fit. Their brain fits very tightly inside the skull. And so they tend to be symptomatic much earlier. In addition, adults, especially older adults, tend to have many more medical problems that might make their normal mentation maybe not quite normal. They have medications that might contribute to that, or just have other medical problems that contribute to that, like dementia and some gait instability already. So picking up something abnormal may not be as easy as it would be in a young, healthy adult. And they also tend to be much more likely to be on blood thinners, which can contribute to brain bleeding. I wanted to just take a moment and talk about another category of pediatric head trauma, that there's this fantastic network that has done great research. It's the PCARN network, and it's Pediatric Emergency Care Applied Research Network. And every ED follows basically these guidelines. It's based on a study of about 20,000 children between the ages of 2 and up to 18. And it really helps us to decide. We all understand why you might do a CAT scan when someone hits their head, but there's also a reason why you might not do it. And that's often not obvious to parents when they bring in a child who's bonked their head. And this study looked at who is safe to not do a CAT scan in, because 1 in 5,000 of those kids is going to develop a brain cancer. So there's a reason to avoid that radiation if possible. We don't want to miss anything, but we also don't want to be willy-nilly about scanning everybody's head, because some of those children are they're going to have a worse outcome because we did that imaging, and they're so low risk that it would be better to have just avoided it. The leading causes of brain injury, number one at the bottom here is falls, which account for about 28% of traumatic brain injuries. Next is blunt trauma, and then motor vehicle collisions. And then fourth on that list is assaults, and that might be domestic violence, child abuse. And then next is blast injuries, which might be explosion or blast. And those are usually from members of the military, but not always. That might be, you're running in the Boston Marathon and suffer blast injuries that are certainly unanticipated. So what do we do to prevent traumatic brain injuries? I mean, a lot of this is pretty straightforward. So it's, taking healthy precautions. So wearing seatbelts, using airbags, always wearing a seatbelt in a motor vehicle, putting a small child in the back seat, making sure they're secured in a child safety seat or a booster seat that's appropriate for their size and their weight. Seatbelts reduce the risk of front seat passenger occupant deaths by 45%. So there just aren't that many things we can do that are going to reduce our risk of death, not just bad outcome, but actually death to that degree. So no good reason not to be wearing seatbelts. This recent mass casualty that was in Orange County, I'm sure you're all familiar, in which there were 40 high schoolers and a couple of teachers involved, going on a band outing. That was a huge incident. Many of those people were found outside of the vehicle. Some had been thrown from the vehicle. It was not a commercial, it was a commercial bus, not a school bus. So I'm sure they had seatbelts, but it wasn't a school bus that would require seatbelt wearing. And I didn't see much reported. I was just at an EMS meeting earlier this week in which this incident was discussed, and it was reported that most of those people didn't have seatbelts on at the time, and I'm sure that contributed. Avoiding alcohol and drugs, not driving under the influence. And that includes not driving with certain prescription medications that might impair your ability to drive. Wearing helmets, riding bike, skateboard, motorcycle, any kind of all-terrain vehicle, and then making sure you're wearing protective headgear when, even playing many sports, contact sports, skiing, skating, and even riding a horse. I mean, I remember when I first my kids started skiing and I got a helmet for my son and I was out there without it. And I thought, like, why would I protect my son's head, but not my own? So, seems pretty quick that I got my own helmet and never looked back. And these days it's pretty rare. Kate, you still see people without helmets, and I don't understand it, but because it just takes one fall, even from a great skier who's going at a fast, even if you're not going very fast, it just doesn't take much when you're skiing on ice to cause a life-altering brain injury. And then I also like to say arrive alive. So don't drive, walk, or cross the street when you're using your phone or your smart device. Those kinds of distractions, either texting while driving or texting while walking, lead to accidents and falls. And texting while driving is illegal in most states, but not Montana, apparently. And then walking and texting causes more than 11,000 injuries last year and more than 5,000 pedestrian deaths. A good friend of ours lost an adult son while he was walking across the street and was hit by someone texting. And every time I take my phone out while walking on the street, I think of this poor mother and put my phone away and say, it's just not that important. Whatever I'm doing is not that important. Get across the street and then I can pull my phone out. So it's a good reminder. For most of us and for our parents and other elderly people, it's really all about fall prevention, given that falls are the #1 cause of traumatic brain injury. So, doing practical things like installing handrails in the bathrooms and both sides of the staircases, putting in non-slip mats in the bath and the shower, removing area rugs and improving lighting around the home, especially around the stairs, and keeping stairs and floors clear of clutter. Regular vision checks and getting regular exercise so that we're in better shape. And then doing balance, improving exercises. My favorite is Tai Chi, but yoga is also very helpful, good for balance. And that gets so much more important as we get older. So what do you do after a fall? You want to look for signs of TBI and get some help. Have a low threshold to seek help after a fall, especially in older adults and very young children who can't really communicate as well as older children, and then look for signs and symptoms of a concussion. We recently at Health Alliance, we are newly credentialed as a provisional trauma level 3 center. If you suffer traumatic brain injury or someone that you care about, I would recommend going to a trauma center because of the coordination of care that these offer and the better outcomes. So when EMS will call us about an accident, we'll activate a trauma based on criteria that look at the mechanism of injury. How did someone roll over in a car? Did they fall from a scaffold? Was it 3 feet or was it 30 feet? And those determine kind of the level of activation that we put into place and who comes and how soon they need to be there. And then we work, to gather more information, get some diagnostics like labs and CAT scans, whatever treatment we need, and then ultimately disposition, or does that patient, are they able to go home? Do they need to stay in the hospital? Do they need to get, sent or flown out to a level 1 or level 2 trauma center that may have a higher level of care than we can offer here in Kingston? And the difference really between, what we had a few months ago and what we have today is this team approach to traumatic brain injury, that it's not just the emergency department, it's the doctors, it's the nurses, the techs, the clerks, the social workers, navigators. Sometimes it's clergy who can help talk to the family members of people who have been injured. But then it's all these subspecialists and specialists. It's the trauma surgeon, trauma PAs, and then all these surgical subspecialties like ortho and vascular, podiatry, obstetrics, urology, neurosurgery. And sometimes it's even cardiology. If someone suffered a heart attack and that led to their trauma, having a cath lab is nice. Sometimes it's a stroke that led to the trauma, so having a stroke team is nice, and all of that's available locally. And then it's all the ancillary services. So from registration and lab and blood bank and radiology, pharmacy, housekeeping, all of those are important. And then the outside community, the EMS and police, but also our transfer center and LifeNet, which is the helicopter service. Treatment of traumatic brain injury really depends on the size, severity, and the location of the injury. And those that are treated at trauma centers tend to have better outcomes. There are some medical treatments for mild traumatic brain injury and concussions. The focus is on pain relief and brain rest. But there's mannitol, which is a sugar that can be given through the IV that helps reduce swelling. There's hypertonic saline, which reduces intracranial pressure. There are anti-epileptic drugs and things as well. And then there are some surgical treatments as well. Not going to spend too much time on these, but here are two different surgical treatments that that might be done. None of these gets done at Health Alliance, but we would, if someone needed either of these, we would need to send them to Mid-Hudson or to Westchester. The top is a ventriculostomy. And if you had like a large subarachnoid hemorrhage that's sort of in the middle of the brain, then it's actually would be blood that's in a space. You could actually stick a needle into that space. You'd have to go through the skull, go into that space, and then literally suck out the blood in order to reduce the pressure on the brain. And then this thing that you see on the right of the screen, that actually measures the pressure, so you'd know how much to take out. When you'd reached a normal brain pressure, you could stop removing the blood from there. And then the bottom here shows another surgical treatment. And that would be a craniectomy. So if someone had a large subdural hematoma, that you could actually access, but not immediately. You have to pull the scalp back and then put some holes into the skull, and then connect the holes to lift off that piece of the skull in order to then access that hematoma and literally, pull it out. Those are rare, but those are life-saving measures for these particular types of brain bleeding. So in summary, hopefully gotten a little bit of information on how to recognize traumatic brain injury, looking at severe headaches, obviously seizing, repeated vomiting, decreased coordination or gait instability. It might be slurred speech. And here's a picture here of unequal pupils. This is called anisocoria, which occurs normally in about 15% of people. And it's good to kind of look in the mirror and know whether you have this. And sometimes I'll ask for somebody's license and try to see on their license whether, if I note anisocoria on an exam, it's good to know that it's old, kind of part of who you are, and not new, because if it is new after a brain injury, it might point to a cranial nerve injury, like pressure on one of the cranial nerves. Have a low threshold to get help with head injury, especially in the very young and older people, and especially those with underlying medical conditions, and especially those who are on anticoagulating or medications, blood thinners, which are incredibly common because of AFib and other cardiac and other stroke prevention strategies. And then if you can, seek help. The best place would be a trauma center, because of the level of expertise and the level of the coordination of care in the services that a trauma center would offer. That's it. Any questions?
Yeah, so I'm reminding everyone to ask questions in the chat. Thank you so much, Dr. Midori. That was a really great presentation. It reminds us all of the things that we need to be doing to keep ourselves safe and to recognize an injury. I have a question right away, and that's, especially when you're working with, in particular with seniors, but also just anyone, how do you tell the difference if you don't know someone fell? How do you tell the difference between like a stroke behavior and, a head injury? Because there seems to be some overlap there.
Yeah, absolutely. It's a great question. And often you just don't know. And so often I want to know, like, how well, if you bring a patient in, an elderly person, I want to know your relationship to them. And I want to know how well you know them. Because if you say, I'm an aide and I've been with this patient every day and something's not right, it's like a parent bringing in their infant, and you just trust them. They might not be able to articulate what's not right, but that like gives the spiny, we call that our spiny sense, that, someone who knows them and says, I'm not sure what it is. I'm just, but they're not right. And, so obviously we're going to start with a good exam of the head. Sometimes there's some injury there that wasn't noticed. But in all likelihood, an elderly person who's not quite right, there's a pretty low threshold to get imaging. And if someone is not quite right in a way that looks like a stroke, if they have new weakness on one side of their body, a facial droop, then if we didn't know that there was trauma, then we might actually bring that patient in and activate our stroke alert, because many of these some brain injuries are strokes. We think of stroke as being from ischemia or being a lack of blood flow, and that accounts for about 90% of strokes, but the other 10% are the kinds that we just talked about. So those are subdurals, those are epidurals, those are subarachnoid hemorrhages, maybe because of trauma, but maybe spontaneously. And so we would probably activate a stroke alert in that case, but have a low threshold to image and to get labs and kind of do a lot more that we might not do in someone who could communicate with us and say, no, I didn't fall and I think I'm acting normally. But we don't always have the benefit of that in elderly people with underlying medical problems.
Oh, great. Thank you. That is actually shed some light on that. I have one other question. I'm looking to see if there's questions in the chat. At the moment, there are not, but if anybody does have any, please feel free to type them in. But this is a question from kind of personal experience, something that happened in my family. Somebody hit their head and they hit their head hard. We brought them to the hospital. Everything was cleared, but they lost hair in that spot where they hit their head for like a month. How does that relate to the severity of the injury?
Probably doesn't relate much at all. And the hair, fortunately, does grow back for most people. But it might just indicate to have lost the hair. Hopefully that got noticed on the exam, because that would be a crucial, that would be a key finding that would, again, lower the threshold for doing imaging. If you didn't have a history of being hit, but you see that there's something not quite right about the scalp.
Yeah, it actually happened several days later. It wasn't at the time of the injury. It was, I think, we were told it was something like the nerves or something that, the hair just died in that spot from the injury. But
Sam, like, we definitely looking in the ears is really important, because sometimes it's not obvious, but you can have blood in the ears, and that may be from a fracture of the temporal bone that we talked about, which is just behind the ears, and causing some bleeding in there. And that would not be a positive sign. That would not be something that we want to see on a physical exam, and would lead someone to get CAT scanned immediately to look for an underlying injury.
Well, thank you very much. And thank you for your presentation. I think it was really amazing. There is one question from Ruth Stratton. Is it common for the mind to freeze if it's traumatized?
Yeah, it's incredibly common. In fact, I didn't talk much about it here, but it's really common to have no memory of that event. I'm not sure if that's what you mean, but it's the findings can be subtle, but having no memory of that event, or even having something we call perseveration, where you ask a question and you get the same answer, and you might, or someone might continue to ask you this, like, where am I anyway? And you tell them, oh, you're in the hospital, you hit your head. Where am I anyway? You're in the hospital, you hit your head. And we call that perseveration, where someone continues to kind of ask something. It seems inappropriate, but they just don't recall that they just asked that. So I think that's incredibly common. And some of that may be protective, that there's not a whole lot of benefit in remembering when you get, you suffer something that's probably painful, but also just traumatic. Not a lot of benefit in remembering that, but a loss of memory to that is certainly common.
And the last question that we have from Stacy is, what do you mean by brain rest after a concussion?
Yeah, there's a lot of research on this, and some of it is sort of changing even now, but especially for concussions, for years we've told people, okay, your kid bonked their head playing football or soccer, they need to spend some time at home. You're not going to go back to practice right away, and you need some brain rest. So things like video games, I mean, you think of, you're kind of not really paying attention, but that actually requires a lot of brain cells to play a video game, to do something on your phone. So we say, put the phones away, just try to relax and try to, watch a movie, just do something that doesn't require a lot of focused attention. Even schoolwork might be something that they need to take a break from. So not just physical activity, but actually activity that kind of requires more of the brain. So we try to give the brain a little rest.
Well, thank you again. It was very informative. We really appreciated it.
You're
So we're
welcome.
going to bring on our next presenter. Let's see. Let me just bring
Melinda, I'm sorry to interrupt, but did you want to do the poll real quick for that one?
Yeah, that's actually, yes, if you could launch that poll. This is just an evaluation, everyone, and just throw your answers into the poll. We aren't going to share. We're just collecting an evaluation on all of our presentations and the segments for our meeting so that we can plan. Okay, looks like we got almost 100% answered. We'll give it just another minute. Okay. And we're good. So I'm gonna just close that. And we're gonna bring on our next presenter, Yolanda Brewster. She's a public health nurse for the Ulster County Department of Health, and she will be presenting on vaccinations. Whoops, sorry about that. She'll be presenting on vaccines. So Yolanda, I'm gonna stop sharing and let you come on.
Good afternoon. Thank you for having me here today. My name is Yolanda Brewster, and I am a public health nurse for the Ulster County Department of Health. And today I'm going to talk a little bit about perinatal Hep B protection and the importance of it for in newborns. Today, I will discuss the background of hepatitis, the importance of the hepatitis B birth dose, the effectiveness of the hepatitis B birth dose, the reasons why we should give it to all newborns, and how we can all help. So hepatitis is a liver disease caused by the hepatitis B virus, HBV for short. HBV is found in the blood and other bodily fluids of infected people. An infant can acquire HBV from an infected mother, transmitted during the birth of the baby, a chronically infected member of the household. HBV can cause acute, chronic infections. Chronic HBV infections can lead to liver failure and liver cancers. Symptoms of HBV could include fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, clay-colored stool, joint pain, or jaundice, the discoloration of the sclera of your eye or skin. Risk of developing chronic hepatitis B by age at infection. 90% of HBV infected newborns will develop chronic infections. 25% of infected at birth will die prematurely of HBV-related causes if left untreated. Why a birth dose? The primary goal of administering hepatitis B vaccine at birth is to protect babies from chronic HBV infection, which can lead to the liver failure or liver cancer. Most morbidity and mortality from HBV-related liver failure and liver cancer occur in people with chronic HBV infection. Treatment can decrease liver damage and chances of liver cancer, but there's no cure for hepatitis B. Many people with HBV are not aware of their infection and can unknowingly spread the infection to others. Who is most affected? In the US, rates of new HBV infections are highest among adults aged 30 to 59 years of age, reflecting low hepatitis B vaccination coverage among adults at risk. The most common risk factor among people with new HPV infections was injecting drugs related to opioid crisis and other drug use. The highest rate of chronic hepatitis B infection in the United States occurs among foreign-born individuals, especially Asian Pacific Islands and Africa. Approximately 70% of the cases in the United States are among people who are born outside of the United States. Other groups who have higher rates of chronic HPV infection include men who have sex with men. Effectiveness of starting the birth dose. Post-exposure prophylaxis for infants to infected mothers is 85 to 95% effective when started within 12 hours of birth. Post-exposure prophylaxis, hepatitis B vaccine, and hepatitis B immunoglobulin, HBIG, at birth complications of hepatitis B vaccine series post-vaccination testing for outcomes. Timing of birth dose is critical to achieve the highest rate of protection. Hepatitis B vaccination starting at birth, even without the HBIG, will prevent transmission of infection in 70 to 95% of the infants born to chronically infected mothers. The opportunity. Each year in the United States, about 25,000 infants are born to mothers who are infected with HPV. And not all of their infants receive post-exposure prophylaxis. Some infants are first exposed shortly after birth to HPV by household members or caretakers who have chronic HPV infection. Newborn infants can be protected if they receive a birth dose of hepatitis B vaccine prior to hospital discharge. The problem. Many infants in the United States are not receiving the birth dose of the hepatitis B vaccine. Only about 80% of US infants receive hepatitis B vaccine within 3 days of birth. There's room for improvement to protect the newborn infants in every state. Prevents mothers and infant transmission. 70 to 95% of infections among infants born to hepatitis B positive women. Prevents household transmissions. Protects infants from the infected family members or other caregivers. And it also assists with school entrance for vaccinations. This slide shows the New York State vaccination requirements for school entrance. Sorry, it's a little small. As you can see though, 3 doses of the hepatitis B vaccine are required by school age for school entrance. And without them, exclusion is possible from school until the vaccine series is completed. How can you help? If you are a healthcare provider, you can promote the health of every baby born by making a strong vaccine recommendation. Provide literature and explain the importance of hepatitis B, birth dose, and answer any questions that the patients may have. By supporting Hep B vaccination, we can improve birth dose rates. We can also have referrals to federally qualified health centers and the Ulster County Department of Health for vaccination and more information. This slide will show that we do offer clinics for vaccinations, and the clinics are the 1st and 3rd Wednesdays of every month. These clinics serve to the purpose of these clinics is to serve the population who are uninsured, underinsured, or do not have a medical home at this time. These clinics are for children 18 and under, accompanied by a parent with prior vaccination records. And here are some resources that may be helpful with answering more questions about hepatitis B and the vaccines that patients may have in the community. How can you reach us? This department is Communicable Disease Program, and the number with our hours of operation and the Ulster County Department of Health website.
Well, thank you, Yolanda.
Thank you.
Reminding everyone to ask questions in the chat. This is really important information, and a lot of us work with, a population that we could be sharing this information with. And I guess I would say, just in our own hospitals where people are giving birth, I'm assuming like any vaccination, parents have to sign for it. How does that work? Do you know?
So in the hospital, if the mother is hepatitis B positive, strongly encourage for the baby to receive the HBIG, the immunoglobulin, and the hepatitis B vaccine 12 hours after birth.
Okay.
And the parents can sign for consent at that time. And they can also refuse, but we do our best to educate.
Well, it seems very, very important information, and really important to be sharing information about the availability of vaccinations through the health department with, again, all of our constituents that work with us in, that we work with in our programs. So many of us are working with people that could take advantage of that. So thank you so much, Yolanda. Anyone else have any other questions? Okay, much appreciated. Thank you. Okay, so we have completed our presentations and we're moving on into other parts of our meeting.
Melinda,
We
sorry
have
to
a poll.
interrupt.
Yeah.
Okay, perfect.
Launch the second poll really quickly, and everybody can take a moment to evaluate the presentation, and then we're going to move on into just doing a little stretching, and we'll move into our networking. We have a few announcements and a couple of things to go through, and then everybody will have a chance to share. So, and again, these are pretty simple questions. Was the presentation relevant to your work or personal life? And once I think we've got 100% answered here, we're all set. So I'm going to close the poll and we're good. Now, we're going to go into our movement break, and we try to, spice it up all the time to teach you new things about ways to stay moving, especially in, our Zoom meetings. Although we're well into a different phase of the pandemic, it's technically over. We're still in Zoom a lot. I have not noticed a huge decrease of sitting in meetings on the internet. So these are 5 ways to stretch at your desk, even when you're in a meeting, and we're just going to go through them really quickly. The first one is just stretching your shoulders out. So I'll just tell you what it is really quickly, and then you're basically going to place one hand under your opposite elbow, and you're going to lift that and stretch it across your chest while keeping your body still, and hold it. So let's all do that together. Lift your arm up, put your hand under your elbow. I've got my right arm here. I'm just going to stretch it, but I'm not moving. I'm stretching this. Don't do anything that hurts. We're just going to do it gently. Get a nice stretch out of it. Hold it for, 10, 15 seconds here. So we're just going to hold. And we'll give that a minute till it feels good. Yay. And I'm going to let that down. I'm going to do the other arm. So up it comes, give myself a little stretch. I've got my hand under my elbow, across my chest, and I'm just pushing it over a little bit, giving it a stretch across my chest, keeping my body still. Get that blood flowing. Yay, feels good. All right, you can release your arms. Now we're going to lift our legs. Now I'm still sitting in my chair. If I wasn't talking about this, you could be doing it in a meeting and nobody would know. So you're sitting in a chair, you're going to hold on to the armrest of your chair or onto your thighs if you don't have armrests, and engage your core, those muscles in your abdomen, and extend both of your legs off the ground. You're just going to flex and point your toes from here. Really, really easy. You're working your abs and you're working some of the muscles in your legs, and you can feel that burn. So you're going to flex and point. Flex and point. We're going to do this 5 times. Flex and point, flex and point, and one more time. And you kind of feel it. You feel it in your abs. You feel it in your legs. We're going to take out and start to work on all that carpal tunnel all of us are working on. We do this thing called talk to the hand. You're going to put your hand out, extend it with your palm facing outward, like you're saying, talk to my hand. And use your other hand to pull your fingers back toward you and hold it for 5 seconds, because that's going to help stretch out that hand that's always typing and using a mouse. Next, you're going to point your fingers toward the ground and push your fingers toward you and hold. And you would normally do this for 5 breaths, but I'm demonstrating it. We'll do it for just a little bit. And then we're going to do the other hand. So we're going to, again, push our hand out and stretch it back. Yay, feels good. And now we're going to point it down and do the same thing. Push your fingers toward you and hold. Then this one's called the bobblehead, and your face straight ahead. Tilt your head towards your ear. Make sure not to move your shoulders. Hold for 15 seconds or so. Don't do anything that hurts. If it feels painful, back off. And you hold 15 seconds and then relax. We're going to try the other side. My other side doesn't work as well, but maybe yours does. Everybody's always got something that's kinked. That side of my neck doesn't move that well. So I need this stretch more than you guys. And then we're going to come up. And the last one that we'll put into our toolbox for things to do while you're at your desk, do the twist. Sit up straight. Place your right hand on the back of your chair. So I'm going to put my hand back here, twist my body to the right. See how I'm holding it? And hold. And again, I'm not doing anything that hurts. It just feels good. It's a nice twist. I'll hold that for a little bit. Back to the front. Then I'm going to do it on the other side. So I'm going to twist and I'm going to hold. And there we go. And we're all done stretching. And this came from, I believe it came from, let me just go back. It's at the top of the slide. It actually came off of Fitbit blog. So you can find lots of these sorts of exercise strategies on the internet, but this came from the company called Fitbit, and we're just doing some of the stretches that were in their blog. So feel free to share this. It'll be in the meeting presentation notes after the meeting. Okay, we have a little bit of collective action to talk about. The last meeting in September, we were talking about a sugar-sweetened beverage policy, and it was shared with everyone after the meeting. If you were in the meeting in September, you received this in an email. And if you read through it, it's really just about your agency or organization committing to not serving sugar-sweetened beverages at meetings and those sorts of things, gatherings, and any meetings that are on your premises. So you'd be offering instead water, seltzer, coffee, tea, natural fruit juice, no added sugar, or 100% fruit juice with no added sugar that's diluted with water or seltzer. So the idea here is if you can help get your agency or organization to commit, and then you let us know, share it with myself or with Stacy. Stacy has a case of these lovely water bottles for your organization. So if you can get your organization to sign on, please do send that to us in an email. And I'll be sending this email again to everyone here after the meeting so that you have the opportunity to get your organization to sign on, and you will receive a case of those water bottles that say Healthy Ulster County. I'm really excited about it. So just letting everybody know that. And it sets a really good example for all of the people that you work with at your meetings, that you're doing this, that you're actually eliminating sugar in your beverages at all of your meetings. So I want to just remind everyone that we also belong to Healthy Ulster Google group. I am so pleased to see the more use of it. All of you are starting to send and share meeting information and events and all sorts of stuff through the Google group. And that's what it's for. You can share with each other. We have a chance to network here today, but you can also share everything that you have coming up, all of the good work that you do and all of the events through the Healthy Ulster Google group, and then we can share it with our constituents. So fantastic. Everybody gets invited to it if you attend a meeting, but if you know someone who wants to become part of the group, they can just email me or Stacy. Also want to remind everyone here that you do have the opportunity to be on Healthy Ulster Radio. It airs early in the morning on Saturday and Sunday on WPPM on Saturday and WGHQ on Sunday. But the beauty of it is you record that usually, I believe, on Wednesdays at 3. So you don't have to get up that early to be on the show. And it's a fantastic opportunity to really showcase all of the things that you do to improve health in the community, or a particular event, or something about your program. And you will work with the health department ahead of time to kind of decide what you're going to talk about. It's really low pressure and a pleasant time. And, everything gets on the radio and it's really great. So if you're interested in that at all, please do contact me, contact Stacy, reach right out to us. Stacy's email is at the bottom here, but we'll also be sharing it at the end. And they're also archived. You can find the radio shows archived at the link shown. And we're going to move on into networking, which is always a great part of our meeting.